Welcome, and thanks for joining this overview of clindamycin. In this talk, we'll unpack how the drug works, where it's most useful clinically, concerns about resistance, and difficile, and practical stewardship principles. So, you can understand both its strengths and the precautions needed for safe, effective use in real-world infections. This slide breaks down clindamycin's mechanism. It binds the 23S rRNA of the ribosome to block tRNA entry and translocation, suppressing protein and exotoxin synthesis, which explains the prolonged post-antibiotic effect shown in the chart, and why it's usually bacteriostatic, but can be bactericidal against some Staphylococcus and Streptococcus, with synergy when paired with cell wall active agents. The clinical coverage graphic highlights clindamycin's strong anaerobic activity against organisms like Bacteroides, Prevotella, and Peptostreptococcus, and lists common first-line uses in combination therapy for aspiration, pneumonia, intra-abdominal sepsis, and pelvic inflammatory disease, while the suggested combination strategy emphasizes targeting enteric gram-negative rods during broad empiric therapy. In practice, clindamycin is often given orally, commonly 300 milligrams every 6 hours, and is useful for cellulitis, abscesses, and diabetic foot infections caused by MSSA and streptococci. The slide also shows how its excellent bone and soft tissue penetration enables outpatient oral therapy, reducing hospital stay, and providing a practical alternative to prolonged IV treatment. For severe toxin-mediated infections, the deck shows how clindamycin's inhibition of exotoxin production is clinically important, especially in necrotizing fasciitis and toxic shock syndrome, where it's used alongside surgical debridement and sometimes IVIG to reduce systemic toxicity, lower mortality, and improve organ failure outcomes in these high-risk scenarios. This page focuses on chronic osteomyelitis and highlights clindamycin's superior osteoblastic penetration, which supports lengthy treatment courses of 6 to 8 weeks, paired with high oral bioavailability. This allows confident oral step-down therapy and helps avoid long-term intravenous access and the healthcare-associated complications that come with it. The pharmacokinetics summary emphasizes roughly 90% oral bioavailability and a half-life around 2.5 hours, permitting 3 to 4 daily doses, with wide tissue distribution, including bone and abscesses. Metabolism is hepatic, with an active metabolite, so no routine renal adjustment is needed, but dose caution is warranted in significant liver impairment. The risk diagram explains why clindamycin carries a higher risk for difficile. Potent suppression of protective anaerobes disrupts the gut microbiome, creating a niche for difficile overgrowth, so management focuses on clear indications, patient counseling and monitoring for diarrhea, and considering prophylaxis or targeted strategies for high-risk or elderly patients. Optimized utilization requires restricting empiric clindamycin to specific high-risk scenarios like toxin-mediated infections, anaerobic sepsis, and proven osteomyelitis, avoiding repeated courses for simple skin and soft tissue infections to curb mediated resistance, integrating rapid diagnostics to enable early de-escalation, and vigilant monitoring for difficile colonization and related complications. In summary, clindamycin offers valuable strengths, excellent anaerobic coverage, toxin suppression, and bone penetration for prolonged therapy, while pharmacokinetic advantages favor oral step-down use. Stewardship means watching for difficile risk, adjusting for liver disease, and preserving activity by limiting unnecessary use so the drug remains a reliable option in the right clinical situations.